Committee will come to order, and I appreciate everybody joining us for today's oversight hearing entitled Choice Consolidation, Assessing VA's Plan to Improve Care in the Community. In late July, we authorized the Department of Veterans Affairs to use a substantial portion of the Choice Program funds to cover a budget shortfall, and in turn, VA was required to submit a plan to the committee detailing how they were going to consolidate and improve the many fractured programs and authorities that the department currently uses to refer veterans to non-VA providers. So we're here this morning so that VA can present this plan to the committee, and together we can measure its merits and challenges. Non-VA care, or care in the community as VA now calls it, is an increasingly vital component of the healthcare system at the Department of Veterans Affairs. Each month, veterans, survivors, and certain dependents of veterans receive approximately 1 million appointments, more than 21% of all the appointments that VA provides from doctors and nurses and other healthcare professionals in community hospitals and clinics outside of the walls of the Department of Veterans Affairs. Allowing veterans to see these providers is vital to ensuring timely and convenient access to care. And I suspect that as the veteran population continues to grow, in both age and in numbers, and as the healthcare landscape continues to shift, the need for non-VA providers to supplement, and note I said supplement, not supplant, the care that VA provides in-house will only continue to grow. I think the success of VA's care in the community program is hampered by inconsistent and competing eligibility requirements, business processes, and reimbursement rates across the 7 methods that they currently use to refer veterans to outside providers. And as a result, non-VA care as we know it today has become unmanageable and unsustainable. The success of the VA healthcare system over the next several years will depend in large part on VA's ability to consolidate these 7 desperate methods to a single coordinated program that's easy for veterans and community providers to understand and buy into, and easy for employees to administer and to manage. And certainly this is no easy task. It's going to require us to have some difficult conversations about the purpose of the VA healthcare system and what it should and feasibly can achieve. It's also going to require us to examine VA's massive physical footprint and make decisions about the future of the facilities that once served a great purpose but may no longer be benefiting the veterans as they should be. The plan that the Department submitted in late October to accomplish non-VA care consolidation and take the first steps towards building the VA healthcare system of tomorrow offers a promising but really kind of a fuzzy definition or vision of the future. And so hopefully we'll be able to dialogue with the VA and bring things into a little more clear perspective so that we can figure out where VA needs to go next. And I'm hopeful that the testimony and the responses to our questions that we'll hear this morning will shed some much-needed light on how VA intends to transform the collection of non-VA programs and authorities that we have today in the coordinated system of care that our veterans have earned. I'm grateful to the Deputy Secretary, the Undersecretary for Health, and the 2 leaders of VA's consolidation efforts for being here this morning to present the Department's proposal. I now recognize the acting ranking member this morning, Mr. Takano, for an opening statement.
Thank you, Mr. Chairman, for calling this hearing today. And access to safe, quality health care is a priority for this committee, and one that veterans who have served expect. We owe them no less. Today, we're going to hear from the VA about their plan to improve access to care. Congress mandated this plan in Public Law 114-41, the Surface Transportation and Veterans Healthcare Choice Improvement Act of 2015. About 2 weeks ago, along with the other 3 corners, the ranking member received a strategic level briefing from VA on this plan. After listening to what VA had to say, she is generally in agreement with how VA is moving forward. During this briefing, VA told her that without congressional support, they could not accomplish all of the tasks set forth in the plan. Today, I am fully prepared to be in a listening mode. I do, however, have some concerns with the price tag that this plan comes with and the ability of the VA to implement this plan throughout the agency. As we all know, VA does not have a great track record when it comes to implementation. The policies are in place, but VA has had difficulty in the past with compliance, as many reports have revealed. VA has told us that the implementation of this plan will be a multi-year process and will require an additional investment of money. I hope today, or in the very near future, we get to hear about the cost. Another concern is this plan seems to be reliant in part on an IT structure that actually works. Congress has been very generous to VA in the past, investing millions of dollars in IT solutions that don't seem to do what they're supposed to do. I do not want to see a repeat of these failures. Mr. Chairman, while I recognize that VA cannot do it all by themselves, especially in rural communities, I want to reemphasize that privatizing the VA is not an option. I do believe that VA, with this plan, is headed in the right direction for providing more and better access to our veterans. I believe that we, as a committee, need to listen today, and if what we hear makes sense, then hold them to this course that they have set out to follow, to ensure that the veterans of today and of the future are assured quality, safe health care wherever they choose to live. Thank you, Mr. Chairman, again for holding these hearings, and I yield back the balance of my time.
Thank you very much, Mr. Takano. Members, we are joined this morning by the Deputy Secretary, the Honorable Sloan Gibson. With him today is the Honorable Dr. David Shulkin, Undersecretary for Health, Dr. Baligh Yehia, who is the Assistant Deputy Undersecretary for Health and Community Care, and Mr. Joe Dalpiez, VISN 17 Network Director. Thank you. It was great to visit with you guys the other morning when we had breakfast. Thank you very much for what you do. And Sloan, you're recognized for your opening statement.
Thank you, Mr. Chairman. As you noted, David, I would further elaborate, has been with VA now for about 4 months. He comes to us from a career in the private sector, managing large healthcare organizations. Baligh has been with us for about 18 months, extensive years of clinical experience, and continues to see patients in the VA system. And Joe has been with VA for over 30 years, much of it as a medical center director. He has spent the last number of months as a co-lead working with Baligh on this report. Mr. Chairman, at the committee's May 13th Choice Program hearing, I discussed our need to consolidate our community care programs. I was gratified to hear you say, and I quote, we must all prepare for the choice program of tomorrow, one that brings the universe of non-VA care together under one umbrella, so that the care of our veterans that they need to receive is more efficient and effective regardless of where it takes place. A statement that is echoed again in your opening remarks today. We are determined to seize this opportunity and to make the most of it, and we're grateful to the committee for responding so positively to our indicated need for consolidation. VA is already in the midst of an enterprise-wide transformation called MyVA, which will modernize VA's culture, processes, and capabilities. Our proposal to consolidate community care is definitely a part of that effort. Care in the community has been and will always be a vital component of health care for veterans. When they live too far from a VA facility, when they need care available only in the community, that's only available in the community, and when increasing demand for VA care exceeds existing capacity, as we have seen in recent years. We're referring veterans to community care more than ever before, but as you noted in your opening statement, Mr. Chairman, we're saddled with a confusing array of programs, authorities, and mechanisms that greatly complicate the task of ensuring veterans getting the care that they need when and how they need it. Those include Project Arch, PC3, Choice, 2 different plans for emergency care, affiliates with other federal agencies and academic partners, and then numerous individual authorities. Each of these has its own requirements, different eligibility rules, reimbursement rates, different methods of payment, and different funding routes. It's all too complicated for veterans, for providers in the community, and for VA staff. Consolidation will improve access and make the process easier for veterans to use. Veterans will have better access to the best care outside VA. Providers will be encouraged to participate and to provide higher quality care, and VA employees will be able to serve both better, while also being good stewards of taxpayer resources. Our report is based on input from veterans, the independent assessment, veteran service organizations, VA employees, federal stakeholders, and best practices in the private sector. We also appreciate the many discussions that we have had with the committee's staff. The report focuses on 5 functional areas: veteran eligibility, a single set of eligibility criteria based on distance from a VA provider, wait time for VA care, and availability of services at VA with expanded access to emergency and urgent care. Second, ease of access, streamlined business rules to speed up and simplify the referral and authorization process. Third, high-performing networks, partnering with federal academic and community providers to offer a tiered provider network, which will enable VA to better manage supply and demand and monitor healthcare quality and utilization. Fourth, better coordination of care. It's a critical item, making health information easier to exchange and helping veterans make the best choices among community care providers. And lastly, prompt provider payment, improving billing, claims, and reimbursement processes to allow auto adjudication of most claims and faster, more accurate payments. These efforts won't just improve the way we do community care, they will make community care a part of the fabric of VA care, making VA a truly integrated healthcare system. Getting there will take time, but even as we work toward the longer-term solution, we're working to improve the veterans' experience of care in the near term. We've already expanded the provider base by including providers participating in Medicaid. We've eliminated enrollment date and the combat eligibility indicators as factors limiting choice eligibility. We've defined additional services as qualifying for exceptions to the 40-mile rule, and we've added urgent consult scheduling to get veterans seen in 2 business days when it's necessary. In the coming months, we expect to accomplish a number of other close-in objectives: a streamlined referral and authorization process, standardization of our partnerships with DoD and our academic affiliates, critical make versus buy decisions on information technology and contractor support, and successful application of my VA customer service systems to community care coordination. These objectives will be the work of an enterprise-level community care team dedicated full-time to improving and consolidating community care, and led by a new Deputy Undersecretary of Health for Community Care. We're eager to move forward with consolidation, but it must be a collaborative effort with Congress. The consolidation, like many of the improvements we've already made, is only possible with your support. We need Congress to provide the necessary legislation to support change and the required funding and resources to implement and execute the consolidation program. I know that costs are an issue, but the critical cost right now, I believe, for our focus is the $421 million we expect to spend on systems redesign and business solutions in fiscal year 16. Other costs will come later as we tackle other aspects of consolidation, such as expanding emergency and urgent care. But our initial investment in one-time improvements to systems and solutions will enable us to exercise more control over the veterans' community care experience. We've detailed our specific legislative proposals in the report. We've briefed their structure to your personal staffs, and we are happy to work with any member on these issues. Thank you for the support that you've already shown. We look forward to working with you to fully integrate care in the community into the VA healthcare system.
Thank you very much. You talked about needing legislation to be able to do some of the things you need to do. What things can you do without legislation? And talk to me about the things that you've already done.
respond?
Sure. Thank you very much. That's a great question. There are definitely some things that would require some legislative approval, but we are moving out today to do things that are within VA's control. And we call these quick hits. These are things that we hope to get accomplished in the next couple months. And these include things such as streamlining the referral and authorization process. Right now, it's very complicated to send someone out into care in the community. There's a number of steps that our employees have to go through and veterans have to go through. Those are some things that we can lean up and make it better. We want to really build on our core network, which is described in the plan, by standardizing sharing agreements with our DoD partners and our academic affiliates. Right now, every single individual VA medical center and their partner has a different agreement. We want to move towards a standard template that can actually start to tackle quality and specific issues. We want to leverage some of the MyVA work that's going on as it relates to customer service and start embedding that into community care. And as the deputy alluded to, we want to carry out some critical make-buy decisions to determine if we need to purchase specific programs or solutions, or we need to outsource them to the private sector. And then during this time is also we want to create really the implementation plan, where we create a timeline of the next steps and milestones that we would have to meet to accomplish the plan. So those are some of the things that we hope to do in the near term.
Sloan, can you talk about, under the new Veterans Choice Program, whether or not you will use a third-party administrator to manage the non-VA care networks, or are you wanting to bring that in-house?
I would, as Baligh alluded to, there are a series of functions that have to be performed. Creating the provider network, managing the claims process, including claims payment, some of the customer service dimensions like scheduling. So there are a whole series of functions, and what we are committed to do is in each one of those cases to make a very deliberate make versus buy decision. The only two criteria being what's best for veterans and what allows us to be the best steward we can of taxpayer resources. And I would tell you the one you've just noted is one of those where we will make that make versus buy decision and do what we believe is right for veterans and right for taxpayers.
Because the two people that are already working within the program have already set up networks, and I'm just trying to figure out, is it a duplication to go back and bring more folks in-house? And I'm glad to hear that you're going to look at that very closely. Let me also ask you about the change to the 40-mile issue. In the request or the report, you talk about changing the 40-mile from a primary care provider. Why not allow veterans who can, I mean, because if somebody needs cardiac care or some other type of specialty care and there is not a provider within 40 miles, they're being hampered from getting care closer to home. And that's, I think, the focus that we're all trying to make is to allow the veteran to get the care closer to where they live.
Mr. Chairman, I certainly we understand that point, and I do think that you're correct that providing services closer to where veterans reside and making it more convenient is what we want to do. That really will end up being a choice that we're going to come back and need your help with, because that would require significant new resources to be able to fund that type of access delivery. So if that's something that we were provided the resources with, we would absolutely work to provide that type of service.
And I think it's
I would also add, if I may, the authority that you've very recently given us to expand the aperture of undue burden really gives us some flexibility today, the authority today to make some of those decisions at the margin where, for example, cardiac care, where a veteran ought not to be traveling 100 or 150 miles for care, we can get that care in the community under choice now.
I think it's interesting that every time we talk about changing or improving a program, especially when you have two dual programs that are running side by side, the VA and the non-VA care, you're always adding additional money and not taking a savings over on the VA side. I know how CBO scores But, you know, we need to be looking at savings. And in the next round of questions, I do want to talk a little bit about that issue. But the one last question I have for you, Sloan, is why is there such a discrepancy with the access to care numbers, the wait times that we currently see in the community when we talk with our veterans and those that VA is reporting out?
I think what you hear, I would tell you, I think VA is delivering great, timely access to care hundreds of thousands of times every single day. Where we fall down is in that 5 or 10% at the margin that aren't receiving timely access to care. I've noted that over the last year and a half or so, the number of veterans waiting over 30 days has gone from about 300,000 now to about 550,000 because we've got more veterans coming to us for more care. And those are the veterans that are going to be the most vocal. Having said all of that, we complete appointments, mental health in about 3 days, primary care in about 4 days, and specialty care in about 6 days. That's the average. So we're providing a lot of timely access to good care. It's just we're not able to do that consistently in every single instance.
So you're testifying to this committee that if a veteran calls and needs primary care, that veteran will get it within 4 days?
I'm telling you what the data tells us is that completed appointments for primary care on average are about 4 days. I have no doubt. I know that there are instances out there where veterans have been waiting a month or 2 months or 3 months to get primary care. I know that. And that's the 5 or 10% that I'm referring to that we've got to be able to address. But the challenge we run into is as we improve access to care, more veterans come to us for care. We completed 7 million more appointments over that 1 year period of time after May or June last year, which should have been more than enough to absorb that 300,000 we couldn't see timely. What happened in the meantime is more veterans came to us.
Do you count emergency room visits as an appointment?
Emergency room visits are not counted in those totals. They are not.
That's not what our staff was briefed. So I'm just, wait. We're going to have this is what our staff was briefed on, and if I am incorrect, let me know that 20% of the appointments are emergency room visits.
No.
And we're being told,
No.
what staff's
No.
being told. Okay.
David?
Mr. Chair, 20% of our visits are same-day access, which means not the emergency room, but they walk into primary care, into their physician appointments, or walk-in appointments. Urgent care can also be considered a same-day access issue.
Okay, that's emergency care, and that's,
No.
I'm sorry, Sloan, do what?
It's a separate, okay.
Sloan's answering, and I can't tell what you just said.
Urgent care would count, but not emergency room care.
Not emergency room care, because that's
Correct.
not, again, that's not what staff was briefed. We'll go back and we'll double check.
Good, and we'll do the same.
If you set a veteran's appointment at 21 days, and you hit that appointment at 21 days, does that appointment count as a wait of 21 days or 0?
It depends on when the clinically indicated date was or when the date the veteran wanted to be seen. If the veteran said, I want to be seen in 21 days, then there's 0 wait time. If the clinically indicated date, the doctor says, I want to see you back in 3 weeks, and we schedule it in 21 days, there's no wait time.
So you're saying that if a veteran calls and says, I want to be seen today, and you say, I can't see you today, but I can see you in 3 weeks.
Then that's 21 days wait time.
Okay, that's the way it's counted. Okay. Mr. Takano.
Thank you, Mr. Chairman. One of my main concerns is how we streamline and improve the flow of information between the VA and community providers, whether that is sharing medical records or improving the billing process. I see that in Phase 2 of the plan, the VA expects to enable medical records sharing between VA and community providers. Can you go into more detail about what that will look like? Am I correct to assume that this will be electronic sharing and not just a sharing of paper records?
Yeah, Congressman, yes, that would be correct. Today, VA gets most of its records through paper. And what this plan is saying is that no longer would be our intent in the future. We would develop a health information exchange. In almost all of the communities that all of you represent, you have active health information exchanges. VA participates in many of those. but this plan would say we would develop a health information exchange specifically to have electronic information come back to the VA to be able to make this user-friendly and in a more timely fashion. This is not complicated technology. It's commercially available, and we participate in many of these around the country, but this would be a specific HIE for this purpose.
How expensive will it be, do you think? I mean, we're talking about small providers and large community providers. I mean, I've heard an earful about ACA and the meaningful use of electronic health records, and many of the smaller providers complain about the cost of this. So do we envision having to come up with more money to enable this to happen?
Congressman, part of the $421 million that the Deputy Secretary referenced in his opening statement would be for us to develop this type of portal, so that part of it would be so that we could get this health information exchange. So that's included in the figures that we would like to have available to us, the flexibility to use money from 802 funds to be able to help develop
Now,
this.
is this just cost to the VA, or are we also looking at the cost to the providers? Because to upgrade their ability, so I'm envisioning these rural providers not necessarily having the capacity. Are we going to enable them through subsidies to acquire the technology?
In my prior life before coming to VA, as a community provider, we participated in health information exchanges. This is so common right now that most providers are now participating in health information exchanges. And while there is some cost to it, most systems, most community providers have already developed these interfaces. So I do not believe that we're looking at a lot of provider burden here. In fact, it should be easier for them than making photocopies and having to send them paper, having to send the VA paper as they're currently doing right now. So I actually think this will be more efficient for the providers.
Okay, in the VA plan, VA indicates that there will be a number of things VA can start doing to move towards the implementation of the plan without additional authority. Can you tell the committee what those are?
Sure, Congressman. I mentioned this a little bit earlier, but the point here is to really try to meaningfully improve the veteran experience and the experience of our community providers and employees in the short term. And so we're moving out to accomplish a couple of things today, and those relate to such things such as streamlining the referral and authorization process that I mentioned, standardizing those sharing agreements with our DoD and academic affiliate partners, infusing customer service training into community care, and making some of these critical alternative analysis or make versus buy decisions. So those are some of the things that are within our control today that we're already starting to act on them to meaningfully improve the experience of our stakeholders.
Well, the choice consolidation plan includes 13 legislative proposals that are integral to the success of the transformation. I know the provider agreement draft legislation that the Subcommittee on Health heard about yesterday is a top priority. Which other proposals are the most important immediately to setting a foundation for success?
I'd be glad to start, Congressman. The very top priority for us is to get provider agreements. Having the ability to be able to contract with the providers that we want, having the ability to work with our key partners, Department of Defense, our academic teaching affiliates, the Indian Health Service, other federal entities, and other high-performing networks around the country is going to be our critical feature here. So we absolutely would like to work with you and have your support in that. Secondly, the flexibility of the community care funds that we've talked to you so much about in being able to have our funding make sense for what veterans are receiving in the community and not making it as difficult to access those funds is absolutely key for us to do. Having the flexibility to access the $421 million from 802 funding, not new funding, but allowing us to access that funding so we can start developing these types of systems that we've talked about here in fiscal year 16 is absolutely critical as well. And I'd ask my colleagues if there are any other key features.
No, those are the critical pieces, and you'll see in our legislative proposal section that we separated those out because those are things that we need today to move out to deliver better care to veterans. There's a middle section of proposals that relate to how we consolidate all the different programs. And then the last piece relates to how we can improve some business and health information sharing processes. So those are kind of how our legislative proposals are divided, and we ask that we focus initially on these immediate legislative needs.
All right, went over.
It's okay. Mr. Lamborn, you're recognized.
Thank you, Mr. Chairman, and thanks for having this hearing. Secretary Gibson, as I understand it from the briefings to staff, the VA previously wasn't tracking metrics for off-VA care. Can you explain why this was not being done and perhaps what is being done now, if anything?
Got it. I think what we were saying before is that because we have such a patchwork of different programs for delivering community care, the CHOICE program, the PC3 contract, our affiliations with DOD and academics, they all are in a silo, and VA doesn't have the visibility that it needs to really assess kind of supply and demand. Do we have the right population of doctors, the right specialties in the right areas? Can we actually assess and monitor quality at the regional and national level? We don't have that level of visibility today. So in the kind of the one-time cost system improvements that we articulate, those are the capabilities that we need. We need to have that visibility at the national level to be able to assess how do we better match supply and demand and how to monitor quality of care for our veterans. So you're spot on. That's what we're asking for.
I think the other light to shed there, VHA has historically operated as a loose confederation of medical centers. And what we're talking about here is moving toward an integrated enterprise. And so oftentimes what I find is out at a medical center level, there actually is a pretty good finger on the pulse of the care that's being delivered by local providers, because providers inside VA know who they're referring patients to. They know about that provider, and they are seeing their patients and assessing that provider experience. But that is not consistent all across the entire administration. We need to operate more like an integrated enterprise so that we've got that kind of consistency.
Okay, thank you for that answer. And I'm going to shift gears and ask about IT. We had a hearing recently, a combined hearing with another OGR committee, about how the VA and DOD is not able to share medical records. But some of what the plan is you're talking about for the future is hinged on a cloud IT system for better sharing between the VA and community providers. So if the DOD and VA haven't been able to really integrate after 17 years, why do you feel it's going to work to do something differently with the community providers in the VA?
First of all, as it relates to interoperability with DOD, this came up at our breakfast the other day, and I would plead with any member of this committee, give us an opportunity to come over and demonstrate for you today what's happening, the information exchange that's happening between VA and DOD. We routinely offer those briefings. We get staff coming, but we never can seem to get a member to come. And so please, we would love to have to come. I'll come too, and we'll put on that demonstration so that you can see we're exchanging electronically vast amounts of information with DOD every single day.
Okay.
So we'd love to share that with you.
If the gentleman will yield, members,
Yes.
We will take the VA up on that. It may be an early morning breakfast event. I'll bring the chicken biscuits, and we'd love to see it.
Mr. Chairman, thanks for your initiative on that. I appreciate it. And
The other
cloud
part,
IT.
but the other part of the issue has to do with the health information exchange, the portal that Dr. Shulkin was talking about earlier. Other comments to add there, either?
Dr. Shulkin, can you add anything to that? The cloud IT
Yeah,
system,
yeah.
the community provider sector?
When you come to this demonstration, because I had a chance to see this in North Chicago, one of our integrated facilities with the Navy, as our doctors were going back and forth between DOD and VA systems. So this joint viewer does allow that. A health information exchange exactly provides that opportunity with community providers. So you do use the cloud, and you're able to go back and forth. It's not one integrated medical record. I mean, we'd all love to see that, but the commercial companies are guarding their software protection to do that. So what you have is the ability to see information, clinical information. And I think that's what you get with the health information exchange as well.
Okay, thank you. Mr. Chairman, I yield back.
Thank you. Ms. Brownlee?
Thank you, Mr. Chairman. My question has to do with implementation. Let's just say, hypothetically, today was the day that we approved all the legislation that you needed to move forward with the program. Can you talk a little bit about the implementation and the timeframes associated with that? I know, I mean, I looked at the plan and saw the 3 phases, and I think by the 3rd phase, it's 4 or 5 years out, is my understanding. But there's also a lot of what you classify as make-buy decisions that have to be made that are going to be, I think, really important to that timeline. And certainly thinking about the role of third-party administrators, I think is at least one that I think is a pretty big deal, a pretty big decision on all of this. So if you could just talk a little bit about the challenges, but what your timeline is.
Yes. Congresswoman, great question. First thing which I want to make sure that you understand is that we're out there every day, traveling all the time, and we're hearing from veterans that the current system isn't working well enough for them, and they're pretty clear about this. I know you're hearing the same thing too. So we are not taking a wait until we improve the system approach. We are right now understanding things aren't working, and we're making these types of incremental approaches as fast as we possibly can. We're doing it in partnership with our TPAs and our provider partners, Department of Defense, academic centers. So we are starting right now, and have been actually, to make this better. We want to get there as quickly as we can, and so the timeline you're talking about, I'm going to actually have Dr. Yehia go through.
Yeah, I think that's such a critical point, because the way that we set up the implementation plan or the transition plan is not to have some grand reveal in a number of years. We really want to make incremental improvements. So that's why we came up with these different phases. The first phase is really to develop the implementation plan, those details that you need and we need of milestones and how we're going to get there, those critical make-buy decisions, and then deliver on the what we call minimally viable solutions, incremental improvements. The next phase, which is another year, is to start connecting different systems, getting these capabilities up, and then the third phase is rolling out some of these larger ones and starting to maintain them. I think one thing to remember about implementation, I know IT's been mentioned a lot, is that from day one when we started this plan, we were joined at the hip with our IT colleagues. So our Assistant Secretary for IT, Laverne Council, and her team were partners with us. They helped us develop a lot of these recommendations. They helped us come up with the cost estimates. And now they're standing up a project management team just for community care. So I couldn't agree more that we need to do this as an enterprise. It's not going to be run out of VHA. It's not run out of IT. It's run at the department level. I think the other really important point about implementation and why it's different than before is this collaboration that we've created between field leadership, program office leadership, and also external consultants that have expertise in things such as health plans and value-based care that VA doesn't have all those specific competencies today. So we're assembling these, what we're calling tiger teams, dedicated staff, multidisciplinary, to start rolling out some of the different aspects of implementation, which in my mind makes it unique.
In terms of the make-buy decisions, and again, going back to third-party administrators, so again, that seems like a pretty big decision. And I know that it's been slow in terms of the choice program and so forth, but it's my understanding, I can't speak for HealthNet, but with TRICARE, I know that they've invested quite a bit over the last, 6 months anyway. It appears they're improving, but again, it's going to be customer satisfaction that tells the true story. But give me some idea of your thinking, some of the pros and cons of using our existing third-party administrators or taking all of those services within the VA. And you have 20 seconds.
So You know, I can't stress enough that they are our partners, so we are working with them day in and day out. They're embedded in some of our medical centers, so they're our partners in making the Choice Act work. I think we've engaged some external consultants to help us determine what we are calling an analysis of alternatives to determine what's best for taxpayers and best for veterans. So we are not taking this decision lightly. It's not just we're using all the resources that we have to help us make the best informed decision.
I yield back, Mr. Chairman.
Thank you very much. Dr. Rowe, you're recognized.
Thank you, Mr. Chairman. And Dr. Yehia, you will get all the tough questions being a University of Florida grad, okay, from me. First of all, healthcare is changing in America, as we all know, and we're looking now, instead of just procedural things, outcomes-based medicine. I know we have a VISN director here and who has been a hospital director also, and if you look at the local hospital system, they will know pretty much in that area where they are, who the providers are they can use. And I'll give you an example. At home, we have, and I'll do a little shout out to my own practice, but we have a group of about 500 primary care providers. We formed a Medicare ACO. It's the best performing ACO in America with 25,000 or less people in it. So the VA could easily integrate and get results back from that. Mayo, Scott and White, I mean, on and on. We all, Marshfield, we all know those systems that can provide a lot of care. And I absolutely do believe you're on the right path. I want to support what you're doing 100% because I think this blended system is the one that's ultimately going to provide the care to veterans. I really believe that. And simplifying the system has to be done. It has to be for your sanity and the veteran's sanity, both. So I want to give you a shout out for that. To Mr. Lamborn's comments about the IT system, I have had the fortune or misfortune to be in North Chicago twice in the winter. And it wasn't as seamless as I would like to have seen it as a provider. Seamless, if you're the boots on the ground doctor, something that takes you 2 or 3 or 4 minutes to get information from, you're hopelessly behind it. At the end of the day, you've heard me say this over and over again, having used an EMR system. So we have to have a system that works for the provider because otherwise it doesn't work for the patient if it does. So those things, what I would like to know is what percent of the veteran population do you think will actually utilize this system? Because you got a little bit of an onslaught. I think some of that was a woodworking process. People heard about it and kind of, hey, maybe I can go get that care. So how many do you think will actually be in non-VA care and VA care?
So I think that's a great question. And as a provider in the system, we're trying to design a system that works great for veterans, our providers and employees, and community providers as well. When I see patients, 3 minutes is too long. And so I can't agree more. And so I think it's important that whatever we end up designing in partnership with Congress works for us, because I'm going to be living it day to day as well as I see patients. With that in mind, your question about how many people are accessing community care, about 1.5 million veterans have received some sort of community care. That doesn't mean all of their care is in the community. They might have gone out for a particular procedure or an episode of care, but there are a good chunk of veterans that get their care in the community. Recently, with the expanded choice legislation and removing the eligibility date and the 40 miles from primary care physician, that makes about 900,000 veterans are now eligible under the 40-mile geographic criteria. So there is a big population of our veterans that are now eligible to access community care.
And Dr. Rowe, let me just add, I think what you just talked about, your statement, is a precise articulation of what this plan's about. So I thank you for that. Healthcare in America is changing, and changing rapidly. And this is actually a plan that recognizes that and says VA has to not only keep up with it, but take advantage of everything that's happening good in American medicine. So I used to run our accountable care organizations. It's exactly those networks we want to tap into to get the best care for our veterans.
And it's easily reproducible. I mean, you can get that data quickly back. The health record the electronic health record is a challenge because in ours, where we brought in other doctor groups, there were 40 different electronic health systems. And that is a huge challenge across the country, trying to figure out how to make these things integrate, and that'll be ongoing. But I think the other thing I want to do is that Ms. Brownlee asked us, what is a time frame? If this goes exactly like we think, which it won't, how do you think the time frame will be? A couple of years?
Yeah, I think it's such a critical question. We are really doing this in an iterative way. It's kind of like agile design, as I mentioned before. We're not looking for a grand reveal after a number of years. So we are hoping that even starting today, we are starting to deliver incremental improvements to veterans, employees, and our community providers. After some of these make-buy decisions and, the portal is an example, those take a little bit of time to actually get into place, but that doesn't mean we're not going out today and starting to make the system better. That's our intention.
Well, my time's expired, but I thank you for what you're trying to do. And also, if you could just do one thing, is make sure, and Medicare does a pretty good job of this, is our timely payments to providers. If they're sitting there for months and months and months, they're not going to participate. So I yield back.
Ms. Custer.
Thank you very much, and thanks so much for being with us. I think this is a really important conversation to have, because the conversations I've been having with my VA for several months now, actually over the last couple of years, is that there's just such a patchwork of programs. And they prefer the programs where they can stay in touch with the providers in the community. We've also had some challenges with our third-party contractor on implementing the choice program in New Hampshire. I have to ask one very parochial quick question. We are one of only 2 states in the country without a full-service VA hospital, and we had a special amendment under the choice card to reduce to 20 miles. Can I reassure my folks in New Hampshire that this 40-mile is not going to cause them to be driving over the mountains in the snow again to get to the VA hospital? I told you it was parochial.
Well, no, and we expected the question, quite frankly. So
Thank you. We are dogged in our determination to take care of our veterans.
we deliberately, in the plan, did not address the special circumstances in Alaska, Hawaii, and New Hampshire. And so part of the process here as we work through this is to very deliberately, with all the stakeholders, look at each one of those instances and figure out exactly the right thing for veterans and for taxpayers. And we commit to you that we will do that.
Thanks, we'll be on it. And just having said that, and whether you say 20 miles or 40 miles, this picks up on a previous question. Part of the confusion is that to use this distance when it's not relevant to the care that's being provided, I think is really a dilemma. To say I'm 20 miles or 40 miles from a facility, if it doesn't, look, I need heart surgery. I don't need to go to a primary care physician. So are we going to resolve that particular aspect of this as well?
Yeah, so I think that's a great question, because we heard that from our veterans and our community providers. And the way we articulate in the plan is not to a facility, but to the relationship. And so we say that it's 40 miles from a primary care provider, because in healthcare, that relationship between the patient and the primary care provider is probably the most critical relationship there is. They're the care coordinators, they provide access to specialty care, and so the way that the eligibility criteria or the plan is designed is, if you live far away from that critical relationship, all the Veterans Health Benefits package is available to you in the community. So it's more relationship-based and less facility-based.
Okay, thank you. I appreciate that. And part of what I wanted to get at, and I think this is a goal, is just the confusion of the bureaucracy. And, you all inherited this as well. It's complicated which veterans are eligible for which services, what kind of health care we're offering. And I think there's sort of a built-in conundrum for us on the committee and in the veteran community between focusing on those types of injuries and ailments that come from their service versus those types of injuries and ailments that have to do with aging and other disease processes that are built into the DNA before they even head overseas. In our case, we have 65,000 Vietnam veterans in New Hampshire aging. But I want to keep the promise to them because many of their concerns, healthcare concerns, mental health care concerns, are related to their service. We didn't know it at the time. It took us a while to sort it out, but it's very clear to me now as I meet with these folks, and I'll add in the folks coming back from, we have a high percentage coming back from Iraq and Afghanistan, the TBI, the MST, the PTSD. Can you just comment on serving the whole veteran, if you will?
Yeah, I think you've said this very well, that the current experience today is confusing and overly complex. I would note that this is not purely a VA issue. This is the managed care industry in general, right?
Yes.
Nobody really understands their managed care benefits and the complexity of what's happened in American healthcare.
Absolutely agree.
Right, but we recognize what you're saying. The point of what we're trying to do, this type of incremental change, is to simplify this. If you work with us to allow us to get the flexibility of care in the funding, care in the community funding together, we think that will go a long way towards allowing us to simplify the eligibility requirements, the understanding of what veterans can and cannot get from the VA, and we're committed to doing that early on in this time frame. And we're using veterans focus groups, and we're out there in the My VA efforts to try to make this more veteran-centric.
Well, I look forward to working with you, and thank you very much for your presentation.
Dr. Benishek, you're recognized.
Thank you, Mr. Chairman. Well, welcome. Well, I just want to reiterate what Dr. Rose said, that frankly, I think this is great that we have one way of VA veterans getting access to community care rather than a hodgepodge of efforts. My concern, of course, is the implementation and making it work. Because, I'll give you an example here. Got many complaints from providers in my district about the choice program due to the inability of the Health Net to communicate with the VA and with the private providers. I had a provider that told me they had to wait weeks to hear back from Health Net. They want to update the authorization for care, and they hear back. When they do hear back, they have to spend 40 to 75 minutes on the phone to check on each and every authorization. I mean, this is like this week. So, I mean, I know that this choice thing came in quickly, and you tried to get it, but you know, the implementation of this is what scares me about it. You know what I mean? So, are you aware of this problem with these third-party providers, and who's dealing with that?
Right. We're not only aware of it, we're painfully aware of it. We are hearing this every day, many, many times a day. And so the choice program, which was brought up with the best of intentions, has experienced considerable problems, putting the veteran in the middle, quite frankly, but also the providers. We are working with both TPAs, and the CEO of TriWest is here in this room with us today. We're working with both TPAs. We have gone through multiple contract modifications to make this work better, and we are using pilots in several locations throughout the country. We're actually co-locating the staff from the TPA with the VA staff. One of the things that we learned in looking back upon this, it was the VA staff who had the relationships with the providers in the community and the relationships with the veterans. And when we removed them from the process, problems began. So we're working now with the TPAs to get this.
I tend to agree with your assessment. You know, as you know, I worked at the VA, and you know, I know the guys at the VA, and I knew their local providers. And that system actually seemed to work okay in my community. And then, you know, having somebody there, you have no idea who they are, contracting with you, you know, taking a % of the money, you know, doesn't make much sense to me, to tell you the truth. And I'm not sure that, you know, we were all that happy with the plan to do that.
Right.
Let me just talk to you a little bit more about another issue, and that is this core competencies in the VA and Plan calls for the VA to access non-VA care for veterans outside of certain core competencies that the VA should handle. What are those core competencies?
So I think that's a great question. When we started this process to consolidate care in the community, Joe and I really had to step back because we couldn't look at it just in a silo of how do you make this part of the system work better without figuring out how it interacts with the rest of the system, which is why in the preamble of the report we talk about kind of the future of VA healthcare. And I think the principle there is that we cannot provide every single service in every single location to every single veteran. And that's the concept there. I think we want to move towards that integrated healthcare system, really creating a complementary provider network to internal VA care. This doesn't mean we're outsourcing VA or dismantling the VA. What we want to do is have a more complementary integrated system so that if we're providing mental health care and primary care in that area, we probably don't need a lot of mental health care and primary care docs in the network. We need other things that aren't provided to VA. So we are calling these kind of foundational services that VA would provide. A lot of that is going to be locally determined. As you know, healthcare is local. What's available in one market may not be available in another. But so that's where that spirit comes from. It's how to get to that integrated healthcare system and creating a complementary network.
Well, to tell you the truth, I really appreciate your enthusiasm and your response, and that may be due to your relatively short tenure at the VA. But I'm hoping that will continue. And I know that, the two physicians up there are, relatively new and actually really welcome their input and leadership. And I'm happy to work with you to make this plan happen. I just have my concerns about the pace. Thank you.
I think part of it's because the Gators are 9-1 right now. Mr. O'Rourke, you're recognized.
Thank you, Mr. Chairman. I just want to begin by telling you each how encouraged I am by this report that you produced and your testimony today and your answers to our questions, and how grateful I am on behalf of the veterans that I represent for this initiative. And Dr. Shulkin, you talk about changes in American medicine that you are anticipating and incorporating in the proposal that you've put forward. And it's restoring VA to its rightful place as a leader in American healthcare, who can set the standard and become known for excellence and figuring out problems that are fundamental to how we provide healthcare in this country. So this, for me, as another short-timer who hasn't been here yet 3 years, certainly the high water mark in terms of our work with and collaboration with the VA. And I share, you've heard it from many of my colleagues so far when they're asking you, how long will this take? And Dr. Yehia, you've done a great job of avoiding the question and saying we've got an iterative process and we're doing this, that, and the other. I think I don't want to speak for anyone else, what I'm concerned about is you have just a little over a year left in this administration, and this is a very exciting, necessary, essential proposal to reform VA care. And I want to make sure that you can do, and we can help you do, everything necessary to make it happen. So you don't have to answer that question, but just know that that is the interest. And I, for one, want to help legislatively in any capacity I can to make sure that we get this done. I want to point out a couple of things that I think are really encouraging. The focus on care coordination, which you've talked about, and making it a fundamental principle of excellence for the VA is just so important if we're going to get this done. You mentioned in your report that you're seeing rising demand for outpatient visits and decreasing demand for inpatient hospital beds. And that seems to answer this frustration we have with $1.1 billion overage in Aurora and hundreds of millions of dollars over in Orlando and Las Vegas and New Orleans. We shouldn't be building standalone VA hospitals to only take care of veterans. On top of that, 41,000 funded authorized positions unfilled. We have to prioritize where we're going to focus in the VA. And so core competencies, as Dr. Benishek raised, I think it's really important that is a fundamental aspect of this plan. And I like the way it's articulated on page 18 of the proposal. One question related to this. Secretary Gibson, you've said in a previous hearing that for every 1% increase in VA patient demand on the system, you incur an additional $1.4 billion in cost. Does this plan, through care coordination, investment in IT systems, et cetera, create some of the necessary efficiencies for us to be able to afford greater veteran participation going forward?
Finish. It was actually Bob that used the 1% and $1.4 billion, but I'll own it.
Yeah.
There are certainly efficiencies built in here. As I alluded to in the opening statement, the fact remains that as we improve access to care and as we improve the veterans' care experience, we're going to find more veterans coming to us for care, especially when it is financially advantageous to the veteran, when their out-of-pocket costs are going to be lower to come to VA. So we're going to continue to see that, but there are some savings that are built into this overall cost picture, and I'll ask Baligh to touch on those.
So I think what you see here is that we're moving towards best practices that are in industry. So we talk about by streamlining a lot of these processes, there's less, it's more automated, less manual. Our employees can spend more time with veterans, and so there's efficiencies gained there. By working with high-performing providers in the community, providers that understand principles of high-quality care and utilization management, there's efficiencies there because they're not going to be ordering that extra CAT scan or that may be unnecessary, or they may be preventing an admission for our diabetic that may require an inpatient stay for someone else. So I think it starts with making the system a little bit better, getting the right providers in the network, and then probably the last component is how we start leveraging lessons learned from CMS. So you know CMS is doing a lot of great work in value-based payments, so we are not reimbursing just for episodes of care, but for more outcomes-driven care. So we articulate some of those there. That's the direction we want to move to. We want to skate kind of where the puck is going and not necessarily be tied to the systems today.
Thank you. And again, thank you for your work, and I look forward to working with you on this. I yield back.
Thank you very much, Mr. Huelskamp. Ms. Walorski. I'm sorry, Ms. Walorski.
Thank you, Mr. Chairman. And I also want to add to the panel how grateful I am that you're here as well, and that we sound like we're on the same page, at least in the whole concept of moving forward and trying to be able to rebuild that trust with veterans and the VA. The one question I have is all the way back to when the chairman started on this whole issue of choice. And let me just say, and let me start by saying, you know, I want the VA to be healthy. I want the VA to work for my constituents in Northern Indiana. Unfortunately, so when I sit in these hearings and I listen to every single question my colleagues are asking, I still think in the back of my mind, we are not as functional in the state of Indiana as some of our neighboring colleagues here. And that's my desire. That's the desire of our veterans. They want everything to work for them because we promised them that when they went to fight. And so that's my goal, is to continue to work as closely as we can to get the VA healthy. And so I so much appreciate the report that you have and the plans and that kind of a thing. But I'm still caught in the question that Representative O'Rourke didn't want an answer on, but it will help me to have an answer on when can we see some of this happening? Because, you know, I was on the conference committee back in October when we did the VA reform reset type thing. We still don't really have a choice program in my district in Northern Indiana. And so it was interesting, I just had a phone call with my district staff that works on all of our VA casework in the district, and they were just telling me that just recently we got a call from an actual VA hospital in the state of Indiana telling the veteran to call my office because the VA hospital can't get appointments and can't get anything through for this veteran. And I'm thinking to myself, something is wrong. There's some kind of a clog in the line. And I would ask you guys, and even Mr. Gibson, if you would, I am more than willing to come to that computer IT, show me the world type thing. I'm more than willing to be there. I'll be there. But I'm again asking if you or the Secretary could seriously come into my district, and if we could have conversations about how do we make this work better, because I think that would be one of the quickest ways and much more efficient ways to actually see that there, it just isn't happening like you're describing it around some of these areas of the country? That would be my first question.
We'll do it.
I appreciate
Bob
it.
or I will come. We'll bring some of our medical center leadership from Indiana, and we'll also bring senior representation from the TPA.
I really
part of
appreciate
the
it.
country.
I really do. And then my second comment is back to this choice program, is that, I remember being on the conference committee when we talked about that 40-mile radius. I am and still very, very concerned. When you're looking at areas that have rural places, which are the hardest sometimes to get care to, that's why this evolved in the first place, was like, let's get care to them from a community-based hospital, somebody near them. And one of the things that I find in my district, which is why it's so frustrating to say, if we're going to look at broadening that radius, it's going to cost a whole lot of money. And I know when you're talking about, you need our help, it means money. But it's so problematic in places in these rural areas, and to Representative Custer's point, when you're dealing with winter weather. Winter weather in my state closes states. We have state of emergencies and we can't travel. And I'm finding myself getting involved. The veterans are calling my office and then having me make phone calls to try to get choice implemented. It literally is not rolling out in our district. So can you just comment on that? I mean, when can we see that actually happening?
One of the points that Secretary McDonald constantly makes is the VA is the canary in the coal mine for American medicine. So the problems that you're describing about rural health care are problems in every aspect of health care, getting providers there, getting the right specialties there. VA is looking at this issue. We are desperately trying to hire psychiatrists in El Paso and specialists in Indiana. But one of the ways that we are beginning to do this is to really use telehealth in a way for rural veterans.
Telehealth is working in my district, I will tell you that. But for specialized care and for things like cancer and those kind of, it's so hard.
We are moving rapidly towards specialty telehealth. In fact, people don't realize nobody is doing more telehealth in the country than VA. And we are driving this faster than anybody. And that can't be the total answer, but we have to look towards new technologies.
Right, I do agree.
And we have to get more providers.
And I will give you that. It does definitely works in our state. But I appreciate your willingness to come and help us troubleshoot. I yield back.
Mr. Waltz.
Well, thank you, Mr. Chairman. And I, too, would like to, first of all, applaud the committee for showing that we can simultaneously do our duty of oversight on accountability and start to provide vision for the future, because I think what we're talking about, hearing people, this is our opportunity to shape VA 2050, if you will. And amongst the crisis situation that arose from Phoenix and others, I think this is the silver lining, that we're starting to move towards that blended system you hear about. And Deputy Secretary Gibson, I do have to say, at a time when the VA so needed it, you instill confidence, your candor, and steady leadership is appreciated. And I think that needs to be said publicly, because we're moving for solutions, so thank you. My team and myself, and I know others in here have done this, have gone on a deep dive on this. It gave us that opportunity, working with everyone from HealthNet and TriWest, who you said are here today. Not only they're here today, they were at roundtables in Brainerd, Minnesota with veterans, and at a time when people could have ducked and covered, they didn't. They stood up in the face of this and were very candid. I appreciate that. Private providers, county veteran service officers, the Minneapolis VA, VISN 23, American Hospital Association, and central office of digging into this. People want to fix this. They want to get there, and you've heard it today. It's working. I think the point that was brought up by my colleague from Indiana just brought up, separating VA healthcare from healthcare in general is, you cannot do it. The lack of rural providers in the private sector is every bit as a problem as it is for veterans. My question to you, and I want to be specifics on this, and you've answered it to some degree, but out of all those meetings and out of the things that came, one of the things I'm hearing from the providers, from the private providers, is the standards in the program are not industry standards, resulting in some of them opting out. I want to understand why you think, in your opinion, why are some providers opting out of this? Because I know they want to help care for veterans, but we shouldn't make it at a loss to them. If you could take that one. I know you've answered it to a little degree, but this was asked of my people out there, why this is happening.
If we look at rural areas in particular, two big reasons. One is, and we have this in the plan, we need to continue with or enhance special dispensation for rural providers. The other finding, and it should have been very obvious to all of us, is when we wrote the initial requirements, we wrote in very burdensome requirements for providers. And we know in rural areas, there's a lot of small operations, and what we hear from rural providers is, this is so burdensome for me to participate that I have to hire additional staff, and I can't do that. So when we look at future requirements for a network, we've built in flexibility for special dispensation for different parts of the country, rural areas being one, and we have to take a very critical clinical look at the things that we're requiring them to send back to us. They seem to be the two things that are most troublesome and push people away from our system. And we've learned those lessons.
So can you, when we go forward, will that be a contract thing that you have the capacity to do, or does this need legislative improvements?
So I think it's a combination of both. There are some requirements that we have today that are not industry standard, and the principles laid in here is to move us more towards that. What are the leading practices? So one of them is tying the medical record to claims. That doesn't exist typically in the private sector. Not saying that we don't want records back, but there's other ways that we can incentivize our community providers to get us health information back without saying we're not going to pay you. The critical thing that we would need is provider agreements, and this is a simplified way that we can partner with providers in the community, and those are exactly the providers you're talking about, typically the local mom and pop, small practices. These aren't the large conglomerations that could enter into complicated FAR-based contracts with us. Those, we can work through very complicated contracts with. But the smaller providers won't work with us if we have them jump through a number of hoops that Medicare doesn't require or partnerships with other health plans don't require. So that, I think, is critical for us. If we can get provider agreements passed, it's going to allow us to partner with community providers and then increase access to those providers for our veterans.
That's exactly what they're saying. How quickly can we do this?
We have, I think they're at the last subcommittee hearing, VA presented their proposal, and I think the committee is considering it. I know there's a counterpart bill in the Senate that has been introduced. We'd love for you to move as quickly as possible on that.
Because I don't want to put these people in the position either. It's pretty wrenching for them that they want to do this, and they don't want to be seen as not providing for veterans. So I think that's a positive step forward. Again, I thank you for your work, and I have to say these are some positive developments, and we need to focus on where there's crisis. We need to continue to have accountability, but I think it's important for us to show that there's a lot of good happening too. So thank you for that.
Dr. Winstrup, you're recognized.
Thank you, Mr. Chairman. Very encouraging meeting today, and I want to thank you for listening, because that's what we're seeing taking place here. In the last couple of years, we've had these types of discussions about where I think we should be headed, and we're seeing it happen, and I appreciate that very much. I do agree with the chairman when he mentioned that when we're outsourcing, it doesn't necessarily cost us more if we're lowering on the other side. We may find ourselves, and probably will, in a situation someday where we say we don't need all this physical plant in the VA, and we can reduce our footprint, and so we can save in a lot of ways and continue to work on increasing productivity. I especially like what you were just talking about, provider agreements. If there's something in the way coming from here that it's making that more difficult, then we need to change that. And you're right, especially in rural areas, letting that lone practitioner out there be able to be a VA provider. Which brings me to another point that I don't really think we need to say that this is non-VA care. Our practice, I guarantee you, it was 20-some orthopedic surgeons. We'd have been glad to have a sign out in front of our building saying VA provider and put the VA logo up there. So I think we should shift away from calling it non-VA care, but extending VA care, and I think that'd be helpful.
That's been my campaign for the last 6 months, to eradicate non-VA care from our vernacular, instead refer to it as VA community care.
Well, I appreciate that. The great minds must think alike. I don't know, but I also appreciate what you were talking about with the information sharing, because in our practice, you know, we could go to, a patient comes to our practice, we could get their information from any hospital in the region without having to jump through a lot of hoops, and it makes a big difference. So I applaud you for being in the right direction, and I yield back. Thank you.
Thank you very much. Dr. Ruiz.
Thank you, Mr. Chairman. Secretary Gibson, simplifying and improving the process for veterans seeking community care remains at the top of my priority list and the veterans living in my district. We, as soon as the Choice Act was passed, we held some workshops in my districts with physicians, Tri-West and the VA, and we heard a lot of the different obstacles that were involved, including the enormous amount of bureaucracy and the lack of information that our providers had in order to enroll. The two VA community clinics located in my district are Palm Desert and Baligh. They are the point of care for VA-based care in my district. And I'm eager to make those facilities more veteran-centric, and I believe your proposal, while not perfect, is a step in the right direction. I, too, am a little concerned about the implementation plan and the deadlines and the inherent evaluation and oversight that you have within the plan in order for us to meet the goals that you set forward in the time that you want to set them, and not have another over-budgeted plan, or I should say under-budgeted plan, where we get a surprise bill for billions of dollars in the near future. My questions rely on the fact that we're going to start relying on community physicians to provide care in areas that have low access to veterans' facilities. Yet those are oftentimes the rural, underserved areas, and in my district, we have 1 doctor per 9,000 residents. So how are you going to account for the physician shortage in the community for the general population and rely on them for the physician care for veterans?
If you have the answer to that, that would be great. Because
I have some ideas, we can talk about it.
This is a significant problem for America. VA, I think, can bring to this several things. One is, thanks to your additional authorities in the Choice Act, you allowed us additional graduate medical education funding. And so for us to create partnerships with medical schools and to create new GME spots that focus on the shortage areas and focus in the rural areas is absolutely top of mind.
Well, we should talk. I was senior associate dean of a new medical school that had that exact plan that took my students in undergrad and college from underserved communities into the undergrad, into those medical schools, and developing residency programs in those underserved areas. One of the key places that you can start having your residents go to and that are involved, that are eventually going to go to work at the VA, is at FQHCs. Absolutely. Let me ask you another important question, because I'm limited with time. I have a veteran in my district who's not the only veteran that has told me this story, who had bad, I guess, consequences from the third party not paying their bills on time, and therefore the provider then would bill the veteran. And the veteran didn't have the resources to pay that, and also the veteran was under the impression that the third party was going to pay those bills. My veteran now has poor credit scores because it went to collections, it went to all these other things. What are we going to do to protect the veterans in case there's glitches like that so they don't have their financial harm?
We spend a lot of time right now, our central business office spends a lot of time helping veterans work through these situations. Again, VA is not dissimilar to what's happening in the private sector. Patients don't understand their bills, and third-party payers are sometimes inappropriately billing. So in those situations, we're there to support the veteran. Sometimes the veteran does have an obligation because it wasn't a covered service, but many times we step in the middle to support the veteran. We do not want to see what's happening.
So how do you support the veterans? You take on the cost?
So if I may, I think the perfect example of this is ER care And right now, because of the different rules and requirements that we have, a lot of veterans think they're eligible for that benefit, but get denied the care. And that's part of the reason why we wanted to tackle that.
Great.
that
One
gap.
last comment, because I have about 25 seconds. You know, you talk about the relationship that's important in terms of primary care physician, and you're absolutely right. But our veterans need pain management, that primary care physicians are not trained, they're not pain specialists. They also need psychiatric care. So I believe that that relationship is that the access or the criteria in which you allow a veteran to see a provider outside of the VA or in the community should not just be the relationship with a primary care physician, but it should be service-based. So if they don't have a pain specialist at that VA location, then they are allowed to see a pain specialist within the community.
Yep.
So when is that going to happen? Does it require a bill, or can you guys make it happen?
Yeah, I think that does. I mean, the concept of going from the service would expand the aperture greatly for all those, because we don't have pain providers everywhere. So I think we're open to having those discussions, but those come with significant resources.
I would just add that the pain management is a different issue than the behavioral health. We integrate. When Dr. Yehia talks about primary care, we're actually talking about a team called our PAC teams with behavioral health integrated into the primary care services. Nobody does this on the scope that VA is doing this now. So I think that one's different than the pain management.
Okay.
Dr. Abraham.
Thank you, Mr. Chairman. We were fortunate last week to be able to be back in our district among our veterans, and certainly my study or my tally was unofficial and small, but I did poll my veterans, about 56 to 67, and you know, what I found is what we had alluding to the chairman's statement earlier in this hearing, that up to 62, 63% of my veterans are still having significant wait times. And again, unofficial, small study, I understand that. So I guess my question, Secretary Gibson, to you is, I'm in VISN 16, you and Secretary McDonald were here before. We had some issues that, and you guys said it's greatly improved, and I'll take your word for that to a point, you know that. But are we, and again, it may just be my lack of knowledge, are we able to access the VA's data as to how you figured wait times, the actual tactics and logistics of how you got to those numbers?
We would be glad to come walk through exactly that
and I would
process with you.
appreciate that.
We would be delighted to do that.
I would just like to understand how your figures, how you get to the numbers you get to.
No,
and
we would be
those
delighted to do that, and that includes figuring out whether or not emergency department visits are included in the average wait times, because people keep handing me notes that say that they're included, and I've been told repeatedly that they aren't. So we're going to figure that one out definitively.
Okay, thank you. And Dr. Shulkin, I'll ask you this. Will the veterans be able to choose a community care provider of their own, or will it be from an approved VA list?
The concept here is to have strict criteria that are based on performance, clinical outcome measures, and service measures.
So you'll judge that community provider based on the criteria?
We are going to create
Can I get a copy of
networks.
those criteria?
Yes, yes, we are. This would be still in development, but we have developed two types of principles. One is what develops what we're calling this core service or this foundational service about what VA really needs to be expert in and what can be done in the community. And secondly, the specific criteria on quality and service measures.
Okay, just,
Yes.
and again, what I'm, I guess, more interested in, certainly from my aspect, is just the criteria for the primary care, because I think this is where we're starting, and we've talked about specialists early, and you said you would need more ropes maybe to go that direction.
Yes, sir.
And the other question I have is, how much cost savings would result from setting all non-VA care reimbursement at the Medicare liable rate?
There are some savings, and I think that they're built into the plan. Do you recall the number?
So I don't have the number off the top of my head, but what we hope to do is move more towards regional Medicare rates, and those rates include calculations for graduate medical education, as you know, and geographic rural areas. That's our intention, is to move more towards Medicare rates. We know we can't get there 100% in every locale, because there's going to be certain geographic locations and certain specialties that in order for them to partner with us, or the community rate is higher than Medicare. So our goal is to move towards closer and closer to a standard Medicare rate that's regional across the country, and allow exceptions as necessary for local communities.
All right, thank you, Doc. And my last question, should the emergent and urgent care expansion that the plan introduces be implemented, will coverage for emergency care be available to veterans who are enrolled in the VA healthcare system but are inactive, which VA currently defines as a patient who has not accessed VA care in 2 years? Dr. Shulkin, you nod your head.
What, the plan that we have proposed for you says that a veteran would need to have active contact with the VA system in the past 2 years to be eligible.
To be eligible for the
Yes.
emergent and emergency.
That's correct.
Care. Okay, thank you. That's all the questions I have, Mr. Chairman. Thank you so much.
Thank you, Mr. Titus. You're recognized.
Thank you, Mr. Chairman. I'd like to first give a shout out to Ghost and the Marine Riders at the Leatherneck Club in Las Vegas. I rode on the back of one of their motorcycles in the Veterans Day Parade. Now, this was a great honor for me, but also I'm no dummy, because in a parade, somebody's going to boo you. But when you're on the back of a Marine motorcycle, you're just getting a lot of this and a lot of this and a lot of cheers.
We want to see pictures. We hope they're on your
That made me
website.
feel really good. Second, I want to thank you, Mr. Gibson, and the Secretary for helping us to get a director for the new hospital. That was very important. You did that. I'm looking forward to meeting Ms. Kearns when she gets there on the ground and working with her, so thank you very much for that. We've heard around the room a lot of people talking about the confusion over the Choice Act and the community care programs. There are different ones, different benefits, and it's not just the veterans who are confused, but also the staff's confused. Now, just about the time they get the hang of that, we're going to change it all over the next 5 years and have another new program. I want to be sure that you are building into your plans ways to train people and to educate the public so we don't have to go through this every time.
So I'll take that's such a great question. And in the actual system redesign and solutions, that first bucket of costs are a lot of resources dedicated to training and communications. And when we were developing the plan, as I mentioned before, we looked towards industry, but also to our partners at DoD and TRICARE. And that was one of the big lessons that we learned when we sat around the table with our TRICARE colleagues, is over their decades experience of delivering such a system, the importance of educating the staff, the community providers, and their beneficiaries on that. So that some of those costs for training are baked in, and in that $421 million we're requesting, that includes some of those exact things, so that people, to eliminate that confusion.
I think that will be very helpful, so that people will know where to go, what they're getting, one program, and understand it, and that'll be a big hurdle that'll be overcome. Another thing, since this is a 5-year program, I think we are seeing move very rapidly the medical marijuana in the states. Half the states already have it. It's recommended. It's legal. Doctors and communities do this, issue cards. We see it in the MilCon bill now on the Senate side, saying the VA can do it for maybe this year. Are you considering this? Let's not get behind the ball again on an issue. Let's get ahead of it.
We would need legislative support to be able to consider that. Right now, as you know, we are not able to offer that. I think that the science on this and the experience in the community that's happening across the country suggests that this is something that we should be looking at more carefully, and we welcome working with you on that.
I just think it's going to be a community health issue, and if we're moving for more of that kind of service, we need to be aware of it, not put our heads in the sand on this issue.
Would the gentlewoman yield for a question?
I'll yield.
My understanding is that we in Congress passed a law saying that the VA doctors, even in the states that is legal, they cannot administer marijuana.
I appreciate that, and I'll take my time back. I understand that is the case, but I also understand that it has been put into the Milcon bill on the Senate side for 1 year, that in states where it's legal, the VA can't refuse to do it. So I don't know if that's going to be part of the compromise or not, but I hope it is. I'm supportive of that. But either way, it's an issue that is moving very rapidly, and we need to be on top of it. Mm-hmm.
Mr. Kaufman, coming from a state where marijuana is legal.
Thank you, Mr. Chairman. I think you're going to bring those chicken biscuits, and we're going to have some brownies from the state of Colorado. Ouch. Mr. Gibson, could you touched on, first of all, I think this is moving in the right direction, but you did touch on some issues involving TPAs, the third-party administrators, and I think being at a decision point whether or not you ought to move that in-house and what the problems are. Could you just briefly touch on some of the issues again that you see with TPAs?
Well, first of all, and we do this every single day. I think the guys get tired of hearing me do this. I say, guys, we're just going to do the right thing for veterans and what allows us to be the best stewards of taxpayer resources. So as you look at all the different functions, scheduling would be a function, processing claims would be a function, building and maintaining the provider network, and I'm sure I'm leaving some out. So you've got all these different functions. In every case, we've got to make a deliberate decision. Do we do this ourselves, or do we outsource it? And the criteria are just that simple. What's right for veterans, what allows us to deliver the best service to veterans, and allows us to be good stewards of taxpayer resources. So where it makes sense for us to outsource, believe me, we're gonna head off in that direction.
I would encourage you not to bring the third-party administrative function in-house, simply because I think you've been objective with this committee on problems with third-party administrators. I think we've had a problem, quite frankly, when issues are done internally. Sometimes we just don't get those reports that are accurate. My situation with a hospital in Aurora, Colorado, where we've been told, even despite the fact in 2013 there was a GAO report that said this hospital and 3 other hospitals that were currently under construction were hundreds of millions of dollars over budget, years behind schedule, that we would be told by Mr. Hagstrom before this committee that everything was fine and it could be built for $604 million. He testified in Colorado last year in a formal field hearing that it could be built for $604 million. Then all of a sudden, the VA loses litigation. In December of last year, the general contractor walks off the job and says, we're not going to come on the job unless VA is off the job. Army Corps of Engineers steps in, does an assessment, and comes up with a number of $1.73 billion. So I just think that I like the idea that there's this tension between yourselves and a private entity, and that you're objective with us in terms of the problems. Because what we tend to do is find out problems from whistleblowers or litigation in the case of the Aurora Hospital. And so I just want to encourage you that whatever issues you have, make it work with them, because I think that the problems would be much greater in-house, and we, quite frankly, would not be made aware of those problems on a timely basis.
Congressman, I would just say, as the Secretary says, as the Deputy Secretary says, and as I say, this is not business as usual. We have learned painfully from those lessons, and we're looking at every issue as they make by.
I'm sorry, but you know, God bless you for trying, but we get that every time, every year. Every year, there are VA leaders that step before us to say, it's going to be different now, we're going to change now, the culture is going to change, it's newer, bigger, better, and then the following year we find out it's not newer, bigger, and better, and the same problems exist, if not deeper. So it is what it is, and I think you mitigate that by using things like a third-party payer, and I think that arm's length distance between them is positive, and I think, make it work, because I certainly will not support expanding the VA bureaucratic footprint after the experiences I've observed being a member of this committee. Mr. Chairman, I yield back.
Thank you very much. Mr. McNerney.
Well, I thank the chairman, and I thank the panel for having a welcome, positive hearing today. The thing that I'm concerned about is you have a plan to consolidate the purchase care programs, and maybe I missed your testimony earlier on that, but what's the basis for believing that this is going to be a better provider than what we already have or what's already been tried in the past? Is there a statistical basis? Is there a model that you've seen that's made this transition? What makes you think that this is going to be a better program?
So, thank you. I think that's a great question. I think the goal here was that we have a number of these different programs, this patchwork of different community care programs. We want to move more towards a standard, what we're calling a high-performing network. And so we think this is good because this is where healthcare industry is moving. We've learned lessons from our federal partners, such as DOD and TRICARE. And at the end of the day, we want to create that seamless connection to a complementary network in the community that veterans can access. And we are basing that on things that have been demonstrated well in the community, in the private sector.
Okay, have there been any coordination with the DOD in terms of transferring data or care information so that veterans that are recently out don't have to go through the huge rigmarole?
Yeah, when we first started this effort, we worked very closely with our DOD partners, again, recognizing them as having many similarities to VA. They operate TRICARE. And so we sat down with them on multiple occasions to learn about lessons learned, best practices, and we continue to work with them. The concept of embedding some of our TPAs in our medical centers, that was something that TRICARE did. And so we're using a lot of those lessons learned from them.
I mean, one of the biggest concerns we have is the transition between the DOD and the VA. I've often thought that we just need to have a czar that can tell people what to do instead of having bickering back and forth. But so you're saying, hey, this is actually happening. We don't need to have a big gun that's going to make this happen. Is that right?
Yeah, yes, that is correct. DOD has been very integral and supportive of our move towards this type of new plan. And we have several oversight committees that we jointly chair between DOD and VA, where this is a standing agenda item. We're working in between meetings, but also have oversight over this. And actually, I think from my perspective, this is going in a very positive direction.
Yeah, I would tell you, we all spend a lot of time out in the field. There are countless examples of close collaborative work locally between VA facilities and DOD medical treatment facilities, where they're just doing amazing. I was in Charleston, South Carolina. Baligh and I both were down there last week. And I went out to Goose Creek, where we jointly operate a clinic with the Navy. And one of the things we were able to do is jointly fund the purchase of an MRI. And what you find is you got a DOD doctor, you got VA med techs that are running the facility day in and day out. And on 2 days of the week, you'll find DOD patients coming in. On 2 days of the week, you'll find VA patients coming in. It's that kind of close and collaborative relationship, and it's happening all over the country. The one other issue that gets at this VA-DOD collaboration that I sort of sense you're alluding to has to do with the exchange of health information. And before you arrived, the chairman has agreed to buy the chicken and biscuits for us to come over and do a demo for the members of exactly how we are exchanging information today, day in and day out.
Okay, that was going to be my next comment, is how useful would it be for members of the committee to actually see that. So the chairman, you're ahead of me. I congratulate you. I yield back.
Thank you, Mr. Huelskamp. You're recognized.
Thank you, Mr. Chairman. I appreciate the gentleman for joining us here today, and some very exciting questions and comments. I have some follow-up I'd like to ask. First, I did have a town hall in Colby, Kansas, which is way up in northwest Kansas, and a veteran was actually leaving that town hall, was going to drive to Aurora, Colorado to pick up a hearing aid. That's a 227-mile one-way drive. Gentlemen, there's a provider in Colby, Kansas that you won't approve. I mean, choice is supposed to fix that. And telling him to drive that far for something he should drive 2 or 3 blocks is unacceptable.
We
So
agree completely. Shouldn't happen.
it shouldn't happen, and that's what we were hoping to fix. So a couple questions on that, but first on this aspirational document, it certainly is aspirational, especially if you look at the cost. What's the 3-year cost they're estimating to implement this plan?
As I pointed out in my opening statement, the essential cost that we're focused on right now is actually the cost of the consolidation itself. The much larger numbers have to do with anticipated increased reliance and the other module, if you will, which has to do with opening the aperture on access to emergency care and urgent care, which we believe is really, we're not serving veterans well today with the current statutory approach that we have to those aspects of care.
And I agree. And by the way, you did pay that veteran to drive the 454 miles, so that's just a minor savings. But
should make that just.
He also did that same drive just to get the appointment.
Yeah.
If
I can let me make just one really quick comment, because we started working this over a year ago, where we weren't able to use audiologists in the communities because they weren't able to access our advantageous contract for hearing aids. And what we've done is we've changed that. We fixed it so that now an audiologist in the community can actually access our advantageous contracts for purchase of hearing aids. This, what you're describing, absolutely should not be happening today.
Yeah, I agree. But on the budget, if I did the figures correctly and pulling the choice out of that, which is another question, if I read correctly, it's about a $10 billion 3-year cost for implementation moving forward on this plan. Is that the rough and ready figures?
Again, what you're referring to are the costs associated with increased reliance as well as the cost associated with opening the aperture.
Well, I just want to
Medicare.
make sure, because I didn't know if that
the
was...
critical issue at this point has to do with consolidating these 7 or 8 different programs into a single channel for community care that veterans and providers and staff can understand.
I understand the approach here, and I have some follow-up questions on that, but not even including the extension of choice, I think I see the figures as $10 billion in 3 years. So if we're wrong on that, if I'm wrong on that, please confirm that. So it's certainly an aspirational document. There's not going to be $10 billion thrown out there for this. But one thing I want to ask, particularly for the authors of the report, I mean, you only had 2 months to put this together. Can you lay this over top of the 4,000-page independent assessment that said we have a leadership crisis here? And how are you going to fix the I think you got to fix the leadership crisis before you even talk about implementing this massive change. And it's very big. So, gentlemen, if you could provide some insight.
Well, I think I'll let the leadership question to the deputy. What we did with the independent assessment is we pulled out each one of the items that related to community care. So anything that looked like it would line up with our proposal, we literally took word for word from that document, incorporated it, and assured that we're covering it and that it was sensitive to the independent assessments. The leadership part, I'll leave to others.
Yeah. Just very briefly, 2 quick things. The amount of money that we need to get this going to consolidate care in the community is $421 million. The other parts of it are things that...
That's not what's in the numbers. The incremental cost of implementing the consolidation plan, just one portion, is $400 to $800 million annually.
Yeah.
That over 3 years is about $2 billion just for the incremental cost of implementation. So if you can clarify that for the committee. I mean, these are your numbers, so I just had those up.
Right. In fiscal year 16, it would be $421 million incrementally, and those systems then would essentially carry into the future years. You're right. The emergency care that the deputy referred to has a separate price tag that is decided upon that could be decided not to proceed with, or that could be decided to proceed with, and the increased reliance has a separate price tag. That means when you make the system more usable, we think more veterans will come into the system. In terms of the leadership issue, You are absolutely correct, Congressman. This is our critical factor. We do not have a hope of implementing this plan without the correct leadership. And we are focused on getting leaders in to fill our medical center positions, our regional positions, and our central positions, including finding a deputy undersecretary that will oversee this plan who has the experience in managed care and population health to make this successful.
So is this the new undersecretary position that you propose to create?
We have submitted a organizational chart to you that this is a new position because VA currently does not have this level of competency in a senior executive position who knows how to implement this plan.
I agree. And hopefully we might have a second round, Mr. Chairman. I apologize.
All right, Ms. Brown.
Thank you, Mr. Chairman. First of all, let me just say that as far as the leadership team in front of me, I am impressed. And particularly with the medical leadership, with the graduate from the University of Florida. Now on for my question. I understand that TRICARE had 2.5 years for preparation before he rolled out his program. We had less than, 2 months? If you had more time, I mean, we insisted that you roll it out in this time period. We put in some new rules and regulations, particularly as far as pay to the providers. Can you give me some feedback on that?
Having the opportunity now to look back on those 60 days that someone had to write requirements, we learned a lot of lessons, one of which is in the future we probably wouldn't contract out the customer service portion of what we do. We did that, and when we talk about the requirements for what a future network might look like, that really is coming from not only the lessons we learned in the last year and a half, it's really TRICARE lessons as well, as you point out. So a lot of the requirements that you see are things that we envision in a future network based on our experience and things that we would have done much differently if we had more than 60 days to stand this up.
In the draft agreement legislation you submitted to the Subcommittee on Health, you discussed requiring providers to submit medical records to the VA. Will payments to the provider and return of records be linked? There's been a source of controversy for current providers under the Choice Program, and of course, it is about timely payment.
Congresswoman, we recognize that the timely payment issue to our providers is a critical issue because it could threaten access to veterans. And coming from the provider side, I am very sensitive to providing a service and not getting paid. So we are going to be encouraging two things of our providers. The reason why we don't perform as well as we should on timely payments is because only 40% of our payments are received electronically, and the industry standard is above 95%. And secondly, we're adjudicating 100% of our claims when the industry standard is more like 5%. So we want to fix both of those, and we're going to be reaching out to the providers. We saw the article recently about the Florida providers and the amount that is owed to them. We're going to be reaching out to them to ask them to send us their information electronically and de-link some of the requirements for medical record documentation. We do need to get the documentation back to provide good continuity of care, but we want to be providing prompt payment to our providers.
When we collapse the various programs, and you know, it's been a lot of discussion about the Choice Program and the program that we've had in the community for years. But I think it's a difference in the payment, one program over another. What will this plan be for the future?
So that's exactly right. When we looked at all the different programs, they all had different eligibility criteria, different payment rates for providers, different rules that they had to sign up to work with us. So we're trying to move more towards a uniform standard approach. I think as it relates to payment, we want to move towards industry standard, which in many areas is Medicare. And so those are the regional, local Medicare rates. They take into account if you're living in a very rural area or if you have a training program. And so that is our intention, is to move more towards that standard payment, with the caveat being that in some locales, maybe like Alaska or highly, highly rural areas, or certain specialties, we might have to go higher than the Medicare rate. But the standard that we want to move to is towards Medicare.
All right, Mr. Chairman, I yield back, and we're going to have a second round.
Thank you very much. We're going to do a second round of questions. If I can, I may deviate just a little bit from the purpose of the hearing. But, Mr. Secretary, how much money remains in the Choice Fund, and what's the current estimated time of depletion of the current funds?
There's currently, in the 802 section of funds, about $6 billion, roughly. Excuse me. And the rate at which we extinguish that will be very much a function of care in the community utilization during fiscal year 16.
So do you expect that it will be depleted by the end of fiscal year 2016?
I think there's a chance that it could be. We've got about $9 billion in care in the community budget, in our core budget for care in the community for 16. And so as you look at current run rates, we actually spent over 10 in 2015, but there was an awful lot of ramp up that happened over the course of the year. So we could potentially find ourselves exhausting the remaining $6 billion, but based on the numbers I see right now, I think it's less likely that we would.
Okay, I asked the question because in a hearing on the 25th of June, you stated, and I quote, referring hepatitis C antiviral infected veterans to the Choice program is not the best model to provide care for taxpayers or veterans, end quote. And we infused a large amount of money to help you with your capacity. You said you had the capacity internally to handle that, but I've been told now that VA has reduced new treatment starts to about 300 per week, and it is treating only those patients with advanced liver disease. So all of the veterans that are seeking the Hep C treatment are being pushed outside to Choice, and I want to know if that's a true statement, and if so, why is the guidance and the model from care for HCV changed from September?
Yeah. First of all, we appreciate allocating the $500 million that you did to allow us to pay for the pharmaceuticals. We did dramatically accelerate starts during that period of time, and were able to get, I'm not going to remember the number off the top of my head, a very large number of veterans started before the end of the year, expending somewhere over $400 million worth of the $500 million that was allocated. I suspect that part of what's happened there is that we've cleaned out some of the pipeline. We've basically had veterans that were in the queue to receive that care and that were eligible for the care, and that basically we started getting them that care. I also know that the funds, budgeted funds for Hep C in 2016 are substantially, very substantially less than what we had allocated and spent during 2015. And that does create a situation where we've got to ensure that we don't get ahead of ourselves in terms of spending those funds.
And if I might, Ms. Titus talked about a parochial issue, or Ms. Custer, I think it was a minute ago. I have one too, but I have a sneaking suspicion it's not just to the 1st Congressional District. I had a veteran come up to me at a ceremony on Saturday that said that he had been scheduled for a surgery and at a VA facility, and he was called on the Tuesday of that week and was told that VA didn't have any money in order to perform that surgery, and that he would have to be put in the Choice program, which would delay his surgery. And so my question, I guess, is twofold. Number one, why in the world would anything like this ever occur? And number two, it appears to me that there may be facilities that are protecting their internal funds by pushing folks out into choice so that they will have those dollars to utilize them. And can you help? I mean, this was an elderly veteran, and we have since talked with him and gotten the laydown as to actually what was said. But can you explain why anybody would say VA had no money?
Sure. I can't explain that. Please ask John to let me know, give me some particular, I was looking for him, but I don't see him. Ask John, oh, there you are, had your head down. To give me some information on the particular veteran so that we can follow up specifically and make sure that that veteran gets the care they need. Secondly, I cannot conceive of why we would say that we don't have any money to perform that surgery inside VA. So that makes absolutely no sense to me. Third, I would tell you, as we look at October obligations, total obligations in October for care in the community exceeded $1 billion, but only about 140 million of those were for choice. So I can't imagine why we would be telling a veteran, you know, you got to go outside for choice instead of us providing that care inside or either with another community provider. Makes no sense.
Okay, thank you. Ms. Brownlee?
I don't have any further questions, but I just wanted to make a quick apology because I made the common mistake in my earlier comments of calling Tri-West Tri-Care. So I wanted to apologize to Tri-West. I presume everybody understood what I was saying because nobody corrected me until my staff, after I'd finished, said that I kept saying Tri-Care instead of Tri-West. So I wanted to apologize.
Thank you,
Mr. Chairman.
I know Dave appreciates that.
Thank you. Dr. Abraham has no questions. Mr. Huelskamp?
Hopefully they'll be short here. If I might make a request following up on the gentleman that wrote the report, would you go back and read the independent assessment and could provide some direction compared to how you can implement it in the Undersecretary as well? Something in writing so we can wrap our arms around this, and appreciate the chairman's questions about the funds left in choice. I wouldn't want to run out of money with that at a very critical time. 2016 becomes, every 4 years becomes a kind of a silly season around here, and so I appreciate the reference to that. But to follow up with the gentleman that talks about the doctor moving to the Medicare reimbursement rates, which is perfect. That's all my hospitals. I've got 70 of them are looking for in the independent providers. You know, Medicare audiology obviously doesn't work well. You'd have to a different rate structure. But what bothers me as well is requiring these providers and dozens of hospitals to go through a different certification system. Why is the Medicare certification system, which has been around for decades and has its problems, but it's there. They're all qualified for Medicare. And by the way, these hospitals serve more veterans than you all do, those that are outside the system. So explain why we just can't use the Medicare certification system, save all the problem, and move on.
Well, I agree with you. I think what we want to do is move more towards that industry standard. So I think 2 points there, one in terms of rates, and two in how we partner with providers. So the concept of provider agreements, again, going back to that, we had a lot of that is based, and the word provider agreements is based on Medicare. And so it's how we can simply partner with our community providers to be able to deliver care to veterans without going through a complicated contracting process. That's exactly what we're looking to do. And when we think of credentialing, the plan talks about moving just standardized credentialing that everyone else does. So we don't want to require anything. We don't want it to be burdensome for these critical community providers that we need to partner with to deliver care to veterans.
But currently there is a separate credentialing process for just VA compared to Medicare?
Currently there's different credentialing rules for the different programs. So when the Choice Act was written into law, there was actually various credentials that we had to have in order to work with those providers. The committee was able to expand some of those eligibility, so to include like Medicare payments and or Medicare providers and others. So some of those were Medicaid, thank you, Medicaid providers and others. So some of those have been, are in statute or regulation. So if we're looking towards moving towards that standard, we might need your help to change some of these laws so that they are consistent with those standards.
Yeah, and I don't remember those restrictions being in there. I mean, that was my hope. I mean, that would save us all some time, trouble, and money, and folks driving 227 or 400 miles, and that's what we're aiming at. So I appreciate your recognition of that. So, but I have, again, 70 community hospitals could tell you, we've already credentialed, and the payment agreements I understand. I mean, if you can tie into the Medicare rates, I think you've solved about 50% of the problems for these providers and for their veterans. So I appreciate that and appreciate the response. And if you put this in writing as well so I can understand that, Mr. Chairman. So thank you for the time.
Thank you. Ms. Brown, do you have any further questions?
Yeah, just a comment. With the change of the presidential administration in 18 months and the turnover of higher level employees in the VA, are you concerned about starting the consolidation program and then having it stall? And just, I've been listening to some of the candidates speaking. They clearly don't have any understanding about VA, the operation. And I mean, comments what candidates make, someone has been in an emergency room waiting to be seen for 8 hours. Bull. So can you respond to that?
I would love to, and I would tell you two different thoughts here. Number one, what we're trying to do is to lay out a path that has been developed collaboratively with Congress, with VSOs, with the provider community, so that this winds up being something of an inexorable direction that we want to head for care in the community. The second thing that I would offer up, I think one of the vital roles that this committee can play is helping to ensure some continuity of effort across the administrations. So as we work together on developing some of these solutions, having this committee and all of Congress, frankly, Senate committees, as a collaborative partner in this process, it gives you an investment in the direction that we're taking so that there is some expectation that that continues in the future administration.
I agree 100%. This committee that I've been on for 23 years have always been very bipartisan. I mean, when veterans go to fight, no one asks them what party, you know, Democrat, Republican, or Independent. And of course, I think that Congress, you know, for many years, we did not adequately fund the VA. And I am glad that we are now soldiering up. I like that word. I learned it last week, and I'm using it. And we need to do our part. So any final comments?
We're trying to do our best to soldier up too. Okay?
Chairman, I give back the balance.
Thank you, Mr. Brown, very much. Thank you to the witnesses for being here today. We appreciate the effort that you're putting into this consolidation program. We know it's moving in the right direction. There are many, many moving parts. We will have more questions, I'm sure, as the process continues on. But I would ask unanimous consent that all members would have 5 legislative days with which to revise and extend their remarks and add any extraneous material. Without objection, so ordered. And with that, this hearing's adjourned.